Dear Pure Urology viewers, good evening, one and all. Today, our topic is RIRS with suction. The speaker is Dr. Pavan Sai. See, as you all know, RIRS has picked up in the last 2 decades, where we are doing with flexible uteroscope, with holmium laser, thulium fiber laser, up to 1.5 centimeter, 2 centimeter, 2.5 centimeter stones, and it is picked up by the juniors also very well, because can be learnt relatively easily when compared to PCNL. Second thing, suction, to be honest, is applied in PCNL by various people. Fortunately, Indians have taken a lead in this. Initially, I used to see the Twitter videos from Salim Muhammad and from Kerala, as well as the videos from Parimal. These two people very early shared their experiences in the Twitter. After that, Dr. Vinith Gauhar from Chennai, and Dr. Oliver Traxler sir, Dr. Other seniors in the world have also invented some of the suction methods. And I surprisingly, in the Pure Urology, one time Dr. Pavan has shared his video also, and it appeared well. Then when we met in Vizag, he shared his experience. I thought we will listen from him, because each person is thinking in his own terms how the suction affects, whether through the scope can it be sucked, or through the access sheath can it be sucked, where these access sheets are available, how the length, everything. Let us listen from his perspective, because RIRS is done by many people now, and the youngsters will adapt to the new techniques better than seniors. So with that intent, I thought on that day, I asked him to present. With this introduction, I will share the screen to introduce him. He is from Vijayawada, and he is, this is studies, and I will share the screen. So this is a screen. He is, are you seeing the screen?
Yes, sir. Yes.
Yeah.
Yes, sir. I'm sure.
RIRS, my experience with scope and suction, Dr. Pavan Sai. He is consultant urologist, renal transplant surgeon, ARC Hospital, Vijayawada. Assistant Professor, Pinnamaneni Siddharthi Institute of Medical Sciences, which is one of the oldest medical college in Andhra Pradesh, Vijayawada. Areas of interest are renal transplant, endourology, andrology, and pediatric endourology. That is good. He is visiting consultant to many hospitals in Vijayawada. He has exposure of dealing with complex cases during his tenure in DY Patil and assistant professor in PSIMS Vijayawada, that is Pinnamaneni Hospital. He is teacher by profession and he is interested in that. Let us listen from him what is his view, and then with open-mindedness, we will think about this section where it goes in the future. Thank you, Pavan, for accepting the invitation and joining with us. Over to you.
Thank you, sir. Now I'll share my screen, sir.
Yeah.
Good evening, sir. Today's talk is mainly aimed for the postgraduates and early career urologists who have just started doing RIRS. I will try to share my experience from scope to suction, sir. I would like to start my experience from baby steps in RIRS. So, starting from baby steps in RIRS, like initially how you should start. When you join a post-graduation course, or when you start doing when you think of starting to do an RIRS, like what you should do initially in your initial days of career. So first, initially start by being a good assistant, like understanding what and when surgeon wants, like irrigation, suction, or any other things. You should just observe the surgeon, like what he is doing and what he needs, because good assistant is a future good surgeon in making. Next thing is a careful observation is very important thing. Like observe the ergonomics, observe the instrument handling, like how the surgeon is handling the scope, like what are the different movements he is doing while doing the surgery. These all are things that are very important in initial days of your career. And also observe the different laser settings that he is using to break different kind of stones, what are different energy settings, or what are there are different problems he's facing while breaking the stone. Like if you see and learn in the initial days of your career, it will be very useful for you once you start doing the cases on your own, because observation is half learning. At this stage, observation is the best way to learn. Next thing, coming to learning scope basics, like handling, cleaning. I think cleaning is a very low thing, but when you start buying the instruments, cleaning becomes very, very important thing, because once you buy a scope personally, you should take care of it on your own, like cleaning or handling or anything. Because if you learn at this point, it will be useful for you once you become a consultant, or once you set up a hospital, or once you buy your own instruments. Now, coming to the scope, the initial days, like once you get to handle the scope in your initial days, once you get hold of the scope during your initial days of a career, what are the things that you need to learn? The first and foremost is, initially my target was to enter the system with the scope and understand the movements of the scope inside the kidney and inspect all the calluses. Like what I used to do is, when my seniors or my faculty, when they're doing the case at the end of the procedure, I used to take the scope in the last 5 minutes, and I just used to go inside and inspect all the calluses, and I used to get hold of the grip, and I used to go into upper calyx, like middle calyx or lower calyx, so that you'll get used to this scope movements and everything. So getting acquainted with the ergonomics and the scope is a very, very important thing. Once you get hold of the scope, you can do anything with RIRS, because your scope is your best friend in this journey. You should know how to deal with the scope, how to handle the scope, because the scope is your best friend. Next, coming to scope grips, what are the different methods that are followed to hold the scope with the different grips? I would like to share a small video of this, like what are the different type of scope grips that usually people follow. Hi, there are different ways like how to hold the scope. One is finger grip. Like you take the scope like this, place it on your fingers like this, and you close it. And this thumb is on the lever. So this is the finger grip. And the next one is the palm grip. So you place the scope on the palm like this, and then close it like this. And again thumb is on the lever. And the third one is the finger palm grip. Like you place it in the junction of the fingers and the palm like this, and then you close it and take support of this part, and then thumb on the lever. This is the method, the third method which I follow usually. Usually this is my grip. This is how I keep it. Thank you. So there's usually three grips like you're seeing in this video. So whatever grip that you're used to based on your physique or something like that, because if you're having long fingers, you need to hold the grip little bit lower. You need to hold the scope little bit lower. If you have short fingers, you need to hold the scope a little bit higher, because your thumb can need to go near the lever. So you should adjust according to your anatomy of your hand, and then you hold the grip based on your comfort. Now coming to scope movements. So this is very, very important in doing RIRS. So like in what direction you move the scope, what direction you can inspect the calyx in different types of cases. So I just want to share a small video regarding the scope movements. I think this will be helpful by observing the video. Yeah, now coming to the scope movements. So imagine that you are doing right RIRS. So you place the axis sheet now on the right side. Now with the left hand, you move forward and backward. And with the right hand, there are 4 movements. Like this lever, down is for down, up is for up. And when you want to go into right side, with the index and thumb finger, you hold it like this and go inside the axis sheath. Push it forward. And when you want to operate on the right side, most of the movements will be external rotation. So when you do external rotation, we'll go towards the calyx, and then with this thumb go down and up. The left hand acts as a brake, accelerator and brake. If you want to go forward or if you want to come back, you all do with the left hand. With the right hand, you only do with the movements. You go into different calyx and you inspect different calyx to the right hand. So this is down and this is up. And mostly external rotation for the right side kidney. And now when you want to go into left side kidney, So again, the left hand movements does not change. It's like accelerator and brake. You hold it, place it inside the access sheath, push it forward, and once when you go inside, the movement will be internal rotation. When you do internal rotation, the scope tip will move towards the calyx of the left kidney, and with the thumb you do up and down movements. So remember one thing, when you go to the left kidney, it's like mostly internal rotation. When you go into the right kidney, it's like external rotation. The thumb movements remains the same, down and up, and the left hand movements also remains the same. It's like accelerator and brake, move forward and backward. Thank you. Yeah, these are the basic scope movements that one should know before starting any RIRS case. Because in the initial days of career, as I told you, at the end of the procedure, you just go inside the system and then just practice these movements so that it will be useful once you start breaking the stone or once you start doing the case. So now the beginning, this is when you actually start doing the cases. Like till now you have assisted or you have seen someone or you have observed seeing others doing cases. But this is when you are taking responsibility and you are starting to do cases. What are the things that you need to look? Like first and foremost, is careful case selection for any beginner is very, very important. So coming to the stone size, 1 to 2 centimeters is ideal for beginners. Usually, 1.5 centimeter is good, so that it will give more confidence to the surgeons also. And coming to the stone location, as everyone know, upper calyx is the best for beginners because when you enter the system, you go straight directly into the upper calyx. You need not do any deviation for like in middle calyx or in the lower calyx. So it will be easy for the beginners to go and reach the stone first of all. And the second thing is pelvis and middle calyx are also good option. But if you lace the stone in the upper calyx, there are different advantages that we'll talk in laser settings. Next thing is try to avoid lower calyx stone in the initial days because lower calyx RIRS may not reward complete stone clearance for the beginners. Hence, it may affect the new surgeon's morale. Not that you can't complete the case, but it's better to avoid in the initial days so that it will boost your confidence and then later you can attempt lower calyx stones also slowly. Coming to the hardness of the stone, like density. Initially, less than 1000 HU is always better because the faster the surgery, it leads to lesser the complications and it will cause better the confidence of the surgeon. So initial days, surgical outcomes and the confidence, it builds the confidence and builds the mindset for the bigger future challenges that you're going to face in the later stages of your career. And try to avoid different variant anatomies like horseshoe kidneys, ectopic kidneys, duplex kidneys, and malrotated kidneys, etc. Do in normal kidneys so that it will help you to build your confidence in your initial days of your career. Next thing is pre-stenting. Should we do it or not? Thing is, it's always better to pre-stent for beginners. The safety measure for beginners as it assures the easy entry of access sheath across the VUJ. Because now primary RIRS and sheathless RIRS is the current rage among RIRS surgeons. But in my little experience, initial 50 cases, pre-stenting is a must for beginners. Later, you can attempt to do primary RIRS or a sheathless RIRS. But it's always, don't think even after doing 50 cases, I can 100% do primary RIRS or a sheathless RIRS. Just counsel, it's always safe to counsel the patient about the chance of just stenting the patient and just come out. Because even after a experience build up, the patient and relative should always be counseled about possibility of only stenting and avoiding the procedure in view of difficult ureter access. In my counseling, what I usually do is I always counsel the patient that I always stent the patient and come out. If possible, if my scope goes in, I'll try to break the stone and come out. But I'll never assure them prior that I will do the case. If can't, I'll just stent and come out. I'll just counsel for stenting and then if possible, I'll do RIRS and come out. Stent size, that size really matter. Is usual mindset that bigger the stent, more the ease in accessing the ureter. But however, in my little experience, even 3.8 French stent gives similar results. Because ureter anatomy is more important than the stent size. It varies from patient to patient. Next, coming to urine culture. Should we wait for the report or not? It is always preferable to plan the surgery after the urine culture report. Positive culture warrants appropriate pre-op antibiotics. I usually start 1 to 2 days prior pre-op antibiotics if the urine culture is positive. For the cases with negative culture report, single shot of antibiotic on the morning of planned surgery is sufficient. It's coming to selecting the type of anesthesia, spinal and general anesthesia. It is always safe for the beginners to do in general anesthesia because the control of respiratory movements is important for convenience and precision in lacing the stone. It always helps in prevent a mucosal injury and to complete the case a little bit faster when compared to spinal anesthesia. The struggle. Now, what are the struggles that you face once you start doing the cases? The first thing is the duration of surgery. So the longer the duration, the more chances of sepsis. So the ideal duration is between 45 to 60 minutes. Don't try to prolong the surgery. You can do it next sitting, or you can just tend the patient and come out. You can explain him. But landing up in sepsis is a very horrible thing. So next thing is usage of irrigation fluid. This is one of the most important thing in RIRS. Watch for continuous outflow through the access sheath. So make sure that all the time when you're doing the surgery, you keep an eye on the access sheet so that water is continuously coming out through the access sheet. So in my thing, I always tell a person who is assisting me or the sister who is assisting me to inform about the outflow like every 3 to 5 minutes so that I can confidently concentrate on the surgery and then leave this thing to them. There is one similarity between a TURP surgery, that monopolar TURP surgery and RIRS surgery, because both we can do only between 60 to 90 minutes maximum. And then we should always watch for the outflow coming through the TURP sheath and then the access sheath in RIRS. And then coming to the vision, like mucosal injury with the scope or laser can hamper the vision. To overcome this, the beginners tend to use more irrigation, hence increasing the intrarenal pressure so that the possibility of sepsis will become more. So when you see that vision is not clear or because of the damage because of the laser fiber or with the scope, what you do is just go inside and come out with the scope like 3 4 times so that the vision will become clear. Or else now because the suction is the trend in RARS, you can just suck the water out that is there in the kidney and then send the inflow again so that the vision becomes clear. So next, coming to the challenges that one more challenge that you face is number of times the apnea is needed. With the experience comes the fine tuning of adjusting the laser fiber and the scope movements with the patient's respiratory movements. This way, we can reduce the apnea time. Once this level of experience is reached, then you can perform the cases under spinal anesthesia with the same ease and expertise. I think in my little experience, about 50 to 75 cases gives such a hands-on experience to start performing the surgery under spinal anesthesia. You need to match the respiratory movements with the laser fiber because it keeps coming, the stones keep coming and going away from the laser fiber. And once you start hitting the stone, once you try to hit the stone, you may hit the mucosa, you may hit the infundibulum, you can cause injury to the kidney. So I think 50 to 75 cases will do for that experience. Now coming to setting up the trolley, like how I set up the trolley for RIRS case. I'm playing a short video so that will be helpful. So for setting the trolley for RIRS case, we go step by step. First, we need ureteroscope. So we do ureteroscopy to remove the degestant. So for that one, we want ureteroscope and then stent removal forceps. Next, so again, well, for placing the guide wire, we do the ureteroscopy and then we place the guide wire. Like we have guide wires here, like we do 0.032 or 0.035 guide wires. And then, now coming to the access sheaths. This is a longer access sheath which is of 35 centimeters. This is the obturator and this is the access sheath. This length is 35 centimeters. So I usually keep the 35 centimeters and 28 centimeters. So this is a 28 centimeters access sheath. And coming to next one, this is the TUR set that is used for irrigation. And this is the cut TUR set that I use for suction. And this is the connector that we attach to the scope. And through this the laser fiber goes in. And then through this we connect the 100 centimeter 3-way extension wire. We connect it like this. And then for this one we connect the TUR set. and to the other end we can either connect the 50cc syringe for manual irrigation, or we can remove it and then connect the suction wire, so that simultaneously we can do suction and irrigation. Thank you. Now coming to access sheath insertion. So first, while doing ureteroscopy itself, what I do is I go into ureter and assess the accessibility of the ureter. If the ureter is gripping my ureteroscopy tightly, so that is less chances that access sheath is going to pass. You should accommodate the ureteroscope freely, so that you can go inside the ureter and come out freely. So that is one of the indication to assess the ureter. The second thing is, when you place the guide wire, if you feel that the guide wire is fits snugly into the ureter, or if ureteric orifice near the VUJ, so then less chances that you are going to accommodate the access sheath. Now in this, if you can see a slit-like opening in below the guide wire. So you can see some part of ureteric orifice opening below the guide wire. So you should be assessing accordingly. So you should see and assess accordingly if the access sheath goes in or not. Next, while placing the access sheath, you should never push the access sheath through the urethra. So first, what I do is I dip the access sheath in water, because it's made of hydrophilic coating. I dip it in water and then I gently push the access sheath through the urethra. Don't apply any kind of pressure. Just a slight smooth movement of the access sheath will always be useful, and it causes less trauma and or injury to the ureter. And simultaneously, you should be looking at the CM, looking at the tip of the access sheet, and have a look at the guide wire. Make sure the guide wire is not coming down or out of the ureter, because it causes more damage to the ureter. So while placing the access sheet, keep these two things in mind. As a beginners, you always should insert the access sheet under CM guidance. It is always safe and better. And after placing the access sheet, if you see a clear water coming out like this, there are less chances that you have injured something like ureter or something. So it's always keep an eye on the outflow that's coming after placing the access sheet. This will help you once you go inside, you can have a clear vision. So now, what are the challenges that you face while entering? So first thing is, once you enter to the access sheet, you may see the lumen is collapsed or something like that. You just don't push the scope through the lumen. Just wait, or just flush the water, or give little bit of pressure so that the lumen opens up and then you can go inside. So if there is any kink, how to manage it? What is the best thing for a starter or a beginner is, you place the guide wire, you keep the guide wire inside and you backload it over your scope and then go inside with the scope. It will help you to reach the kidney without any damage to the ureter. And never push the scope through the PUJ, as it causes avulsion. Or never push the access sheet through the VUJ, because it causes perforation. You keep these points in mind and then you go ahead with your surgery. So coming to breaking the stone now, you have gone inside and you have seen the stone now. So I'll just explain what is dusting. Dusting is like very low energy with high frequency. So if you see in this video, like how the person is punching the punching bag, so there is like high frequency but very low energy. So that is dusting. We can make small powder or small pieces with this setting. So like, what is fragmentation? Fragmentation is high energy with low frequency. And the same thing you can see in the video, the person is punching the punching bag with low frequency with high energy. So with this thing, you can make into pieces. So you can't powder it, but you can make into big pieces, and then you can do popcorning later on. So dusting versus fragmentation. As a beginner, so you may ask what we should start with or what we should do. Learn to assess the hardness of the stone. In my little experience, I usually start with dusting, and based on the time taken to reduce the volume of the stone, I choose if to shift to fragmentation or to continue with dusting, keeping in mind the importance of total duration of surgery. I prefer to take this decision in the first 10-15 minutes itself, saving on the time. So I just can't keep dusting for like 1.5 hours, 2 hours, because we have to match against the time, because time is very important in RIRS. So these are the initial basic laser settings that I usually start with, dusting with 10 watts with 0.10 joules and 100 hertz. So total of 10 watts, and fragmentation comes around 1 joule and 10 hertz with 10 watts. based on the hardness of the stone, based on the time taken. These are not fixed. Remember one thing, these are not fixed settings. You can keep on increasing or decreasing based on the hardness of the stone, type of duration of surgery and different factors. So don't just stick on to one setting and then keep on hitting the stone with that one. Coming to popcorning is like high energy and high frequency. So usually I start with 12 watts in popcorning. So in popcorning, you you make it into small pieces. You keep it in the center of the calyx and then do popcorning. Make sure you do popcorning in apnea mode, because if it touches the mucosa, it causes damage to the kidney. So make sure it's in apnea and keep in the center of the stone, center of the calyx. So at the end of the surgery, the cysto RGP is very useful to look for any intravasation or extravasation. Post-procedural degescenting is always safe for the beginners because surgeon's peaceful sleep is important. As the experience advances, a uterine catheter can be placed instead in selected cases. Like is a small stone you have completed in 20 minutes and there are no fragments left, because now the suction era has come. Well, if there are no fragments or if there are no powder left in the kidney, you can just put a ureteric catheter, or you can just leave without doing the stent and then come out in later stages of your career, but not in the initial stages of career. But just putting DJ stenting does not harm anyone. It's always safe to put DJ stenting for beginners. So post-operatively, usually I put ureteric catheter for 12 hours and POD1, we usually discharge the patient. Post-operatively, it's important to look for any pain or hematuria or any fever. So look for these symptoms mainly. Now coming to suction in RIRS, this has been the new trend in RIRS. So RIRS with suction is a natural successor to the traditional technique, regulating the intrarenal pressure and aspirating fine dust or fragments. Aspiration device in surgical treatment of urinary stones favors a high stone-free rate, therefore reducing the infectious complication. The various suction methods that are there, suction through the access sheath is called Fan's method. Suction through the scope is the disc method or mist method. So usually I started doing disc method. That is my way of suction is direct in-scope suction. Like I thought a lot of people I started, like sir has mentioned, a lot of people have started doing suction nowadays. So even I thought I should start doing suction and then see how it works. So initially I thought where I can get an access sheet and all these things, but I have inquired in 2 months. This is everything I'm talking about 2 months back or 3 months back. I could not get any contact of access sheet or where I can get it or where I can buy. So I thought I'll do it through the scope. And let's see how it's going to work. So I started doing like direct in-scope suction. So I'll play a small video like how I do it and how I'm doing it. This is just normal plain TUR set that is cut like this. Now this end, there's a three-way and you connect it like this here. Then to other end, connect it to suction like this. So this one is a normal irrigation channel. This one is a suction. And this is a 100 centimeter extension wire. It's connected to the scope. Now, if you want normal irrigation in RIRS, the thing that we do is so we'll just open the channel here, this three-way here, so that the water keeps on coming. Now, when you want suction now, just change the channel to this. So you keep the suction like this. Now once again, if you don't want any suction, just rotate it like this so that normal water keeps on coming. The suction is stopped. Suction apparatus that we are using here. So if you see, we connected one end of the three-way connected to the TUR set. Another channel we cut the TUR set, and through this we connected to the suction. So if you just want suction, now the normal flow is going on, and if you just want suction, we'll just rotate it like this, and the suction is on now. The method I am using for suction in RIRS is DIS, that is direct in-scope suction. In this, the stone is made into fine powder and then suction is done in between and at the end of the procedure. Both suction and dusting cannot be done at the same time. The main advantage of this is no additional gadgets are required for suction other than TUR set. The main disadvantage of this is large fragments cannot be sucked out as they obstruct the channel and may block the channel of the scope. Only fine dusting can be sucked out through this DISS method. Make sure the suction pressure is kept as low as possible. Usually keep the pressure between 100 to 150. Make sure the system does not get collapsed rapidly during suction. In this method, as you see, the scope is taken close to the dust and then suction is done. All the dust is sucked into the scope. Sometimes large fragments obstruct the scope channel and then block the suction. So you just need to flush the water again into the channel so that whatever is stuck inside the scope channel comes out and then the channel is clear. The other method of suction through the scope is MIST, that is manual intrascope suction technique through syringe. Suction through the scope and suction through the access sheath have their own advantages and disadvantages. Coming to the fans method, that is flexible and navigable sheath. What are the advantages and disadvantages of fans method? So I'll just show you fans method and then this method, both advantages and disadvantages. Coming to fans method, the advantages are more complete clearance is seen in fans method compared to the disc method because you suck all the fragments also compared to disc method. But in disc method, only fine powder is sucked. But in fans method, you go to the mouth of the calyx and you aspirate, you suck all the fragments also. Can do fragmentation and suction both at the same time. But whereas in this, you can't do both at the same time. Either you should do fragmentation, dusting or suction at the single time. So these are the advantages of fans method compared to this method. So what are the disadvantages in fans method? In this, no, the disadvantages are more chances of injury to the kidney while placing the access sheath because we take a long access sheath in fans method, like 45 centimeters is good for fans method. So when we start placing the 45 centimeter access sheath, it may cause injury to the kidney if we are not if we don't do it properly or if it's not done under proper guidance. And second disadvantage is can decrease the durability of the scope because we need to bend the scope through the access sheath. So it however hampers the degree of bending in the scope. So it can cause a decrease in durability of the scope. The next disadvantages is fragments can get stuck between the scope and the sheath. So while aspirating, the small fragments can get stuck between the scope and the sheath, and you can't remove the scope out. So in this situation, you need to come out. You need to take the sheath as well as entire scope outside. So next thing is it's comparatively difficult in lower calyx. So because the bending is quite difficult in fans method, the lower calyx reaching the lower calyx is a little bit difficult compared to other calyx. And one of the disadvantages, you need to have an additional access sheath for this thing. And it's and usually also it's costly. And for the beginners, I feel buying this access sheet and doing this will take some amount of experience before starting this method. So I think Chandramohan sir will give a better idea about fans method because he has been doing very good work in fans method. So coming to this method is like that in scope suction. One of the advantage for the beginners is you need not buy any additional gadgets or any instruments for doing this method. You can do it with your scope and then just with a plain TOR set. And then there's less chances of injury to the kidney. Like in this method, because you place the access sheet in the proximal and mediureter junction or below it, or you don't go into the kidney with the access sheet. You don't damage any PUJ or any part of the kidney. But what are the disadvantages of this method? Because only dust particles can be suctioned out. Because the working channel is above 3.6 French. Because 3 French. So only 1 mm, less than 1 mm stones can be aspirated, but it also gets stuck because only fine dust is aspirated through the scope. In my little experience, I have seen that. And fragments can come and get stuck in the working channel. And one more disadvantage is cannot do both suction and dusting at the same time. First, you need to dust the stone. You need to make it the small, very fine powder, and then you do suction. Coming to the suction pressure, I usually start with 100 mmHg negative pressure and then increase to 150. And this is a problem that I usually faced while doing this method. See, these are small fragments. If this thing is seen in fans method, you directly place the access sheet in the mouth of the calyx and then you suck all the small fragments outside. But if you see in this, the fragments are getting stuck to the scope. So what I do is I take it off the suction and I don't on the water also. I just come out and then I come out and then on the water so that all the fragments that are stuck inside the scope are flushed out like this. If you see this, see there are small fragments that are get stuck in the scope. So I come out, flush the water, and then you can see small fragments that are coming out. So this is one of the major challenges in this method compared to fans method. But the good thing is that they are once you flush water, all the fragments and small pieces are coming out through the scope. And in long-term process, you have to see if it's going to hamper the durability of the scope or not. And one more challenge while doing suction in RIRs that you face is, see, the system obviously collapses once you start doing suction. So make sure that system does not collapse rapidly. In this, if you see, the system is collapsing very slowly. So you should be able to see this. And then once you see the system is collapsed, immediately turn on the water so that the water goes inside and then again the system expands. So this is very, very important while doing suction in RIRS. So for this one, you need to handle the irrigation very well. You should be telling your assistant when to stop suction and when to on the irrigation. These are the major challenges that usually we see while doing suction in RIRS. Finally, what is the take-home message that I want to give is it's more important to know when to abort the surgery rather than when to do the surgery. No matter how much experienced one is, one should always treat every case as his first case. Surgical technique is more important than doing number of cases. Learning in a proper way, doing in proper guidance is the most important thing rather than doing numbers. As a beginner, it is important to have a mentor to help you navigate through the difficulties without spoiling your name. Last but not the least, confident thrills, but overconfident kills. A word of heartful gratitude to my faculty in Devay Patil for nurturing the surgeon in me. I would like to thank my faculty there, Dr. Sarath Kumar Kankliya sir, Vilas Sable sir, Dr. Vikram Satov sir, Dr. Sunil Maske sir, Dr. Abhirudra Mule sir, and Dr. Deepak Mane sir. Lastly, I would like to thank Dr. Chandamohan sir for giving me this opportunity. Thank you, sir. Without you, then, this would not have been possible. Thank you for encouraging many young urologists like me for giving an opportunity on such a large platform and expressing our views and ideas on this large platform. Thank you once again, sir. Thank you, sir. Thank you.
Thank you very much. That is nice presentation, crisp, around 45 minutes. Let's have some discussion.
Yes, sir.
Quick discussion. What is the size you select in your practice for RIRS in one setting? Patient doesn't want two settings. He will give option to you. You do RIRS, you do mini PCNL, I don't mind. But one setting I want to finish and go. What is the maximum size you select? Post-stented or pre-stented, doesn't matter.
Size of the access sheet, sir?
No, size of the stone.
Size of the stone, sir. It's like 1.5 is always best for the beginner, sir. Well,
what do you select? Don't what?
I select up to 2 centimeters, sir. 2 centimeters. I select for RIRS.
Which laser you are using?
Sir, I'm using thulium fiber laser, sir.
And have you ever tried holmium laser?
Yes, sir. During my PG days, we used only holmium, sir. After
what is the difference you are finding?
Sir, while breaking the stone, I felt TFL is much more faster when compared to holmium, sir. The duration of the time also is reduced with thulium fiber lasers when compared to holmium. But the only problem is coming is in the ureter, sir. Like everyone knows, like holmium, there is less chances of injury, but thulium, it produces more heat, is causing more damage to the ureter, sir.
What is the worst complication you have seen in your RIRS case? Not seen any?
By God's grace, till now I've not seen, but I have seen a complication where there's a PUJO with ballooning of pelvis and then lower pole stone, sir. I have attempted doing RIRS, but I could not complete the case, sir, because I could not reach the stone because of the ballooning of the pelvis. So I had to abort the procedure. Then I have learnt a few things from that case, sir, because not every case we can do it. So you have
Very
to.
important point. Partial PUJ, please do not attempt RIRS.
Yes, sir. Yes, sir.
Definitely, it is not a good thing to attempt partial PUJ, even after stenting also. If any doubt of passage difficulty, please do PCNL. Okay. Yes, in how many cases in your practice, primary RIRS is possible? That means you take the case, you do the case, you put the stent and finish. How many cases? 90, 80, roughly, what is your...
So, sir, after doing like 60 cases or 70 cases, I started doing like, after I started doing primary RIS, sir. I am more comfortable in doing in females, sir, compared to males, because females, we can put the access sheet more easily compared to males, sir. So if the female patient is there, I counsel them for primary RIRS. If male patient is there, I will counsel them for stunting and then RIRS, sir. But I can't give them assurance that I am going to do only primary RIRS. But in female case, I am giving primary RIRS counseling, sir. Nowadays, sir, I started doing that one. Not in males.
In suction through the scope, what I observed is, I also tried many times.
Yes, sir.
My main problem is when large stones are taken due to lack of patience, repeated obstruction, flushing, obstructed flushing, length of the scope is more, and the laser fiber, when it goes and strucks at the junction where flexible part is there, it may perforate and it may damage the scope is my worry. So I'm enjoying the fan. That's a different issue. Because large volume, if you wanted to take, direct intrascope suction is a problem. And the other problem I'm facing is as you said, that video is very good, slow decompression and slow, fantastic video with a nice pulsating vessel. What is your opinion when it bleeds because of the suction, entire vision goes? Initially, definitely anybody will keep low pressure also. While sucking the dust, it causes capillary bleeding. Yes, what is your experience on that?
Sir, till date, I have not seen bleeding. So, but if there is bleeding, I feel we should stop suction. I think if little bit of water irrigation and then just aspirate, come out, go inside, and then like that, doing like 3-4 times will help to improve the vision. If the bleeding is severe and persistent, I think you need to abort the procedure. I think you just need to place the stent and come out. Even if then bleeding still persists, then you should go for angioembolization or little some procedures like that, sir.
do you use this disc for large stones also? Have you used?
No, sir. No, sir. For small stones, for 2 centimeters, less than 2 centimeters, sir. Like you told, because we have to make stone into fine powder, but at the end of the procedure, you can't make the entire stone into fine powder because
Yeah,
at the end of the procedure, you will have some amount of fragments.
very
That
good, very good.
so I feel. Yes, so I feel so at the end of the procedure, like you have like 5, 6 fragments. It's where you can use basket anytime. Like if you have five,
Yeah,
six fragments, you
yeah,
do dusting. You maximum because no your urologist will be telling you 100% I'll do dusting like that. So at the end of the procedure, I'll prefer to use basket and then remove the fragments, sir.
yeah.
Yes.
Last few questions, two
Yes,
questions.
yes, yes, sir.
Without access sheath, this is more promising actually. Without access sheath, this is more promising because if the ureter is small, if you wanted to take out, make powder and this. Have you tried without access sheath?
No, sir. I have tried without access sheet doing RIRS, but not this method,
Not
sir.
this.
Not this
So,
method.
without doing access sheath, doing RIRS is slightly difficult, but not like if you see the world, 80-90% are using access sheath and 10 to 15% from day one they are using without access sheath. They are comfortable and they recommend, and it is logically good for the ureter because the damages to the ureter are predominantly by the access sheath, not by the flexible scope.
Thank
Last question.
Yes, sir.
Uh, in which case you feel that I will choose PCNL, I will not choose Agile, apart from size, which case you choose PCNL?
So PCNL lower calyx so best for PCNL, sir.
Best for PCNL, correct,
Yes,
very
sir.
good.
Supine or prone, lower calyx is best. And if there is any
Infection, you like to choose
no, sir, no. Infection also is one of the cause. Infection also we try to do PCNL, so that's more beneficial to the patient than RIRS, sir.
matrix stone also. Do you have experience better, no?
Yes,
PCNL.
yes, sir. Yes, sir. Last week we had done one matrix stone RIRS, sir. So because we entered into the system, but there if you have seen, it's like matrix stone, sir. And so with laser, I tried to break the matrix stone, but it was like failure only. So what I did was I took out the forceps basket and then removed the muck out of the kidney, sir.
So
So mat
do you think that the PCNL will completely disappear in the armament era, or it will stay back for some more time?
No, sir. Like what I want to tell is, as a urologist, you should learn PCNL and come out of the college, sir. You can learn RARS anytime in your career, but PCNL, if you don't learn the basics in your PG time or if you don't do it, you don't have that confidence to attempt outside because PCNL is more difficult procedure compared to RARS, I feel, because there are different ergonomics and everything.
It can be rescue both ways. If small stone is left behind in PCNL, RIRS can be done.
Yes, sir.
If RIRS cannot be done, one should know PCNL. So
Yes, sir.
nobody should say that
Yes, sir.
this is going to die, that is going to die. Technology will keep on changing.
Yes, sir.
Chandramohan Godala has asked from Anantapur that with this type can it cause mucosal bleeding? That's why I asked.
Yes, sir. Yes.
I have seen a lot of mucosal bleeding with this. Maybe my suction pressure is more. That's why I am not used to this now.
Yes.
But a little difficult. What is your experience? Sometimes
Yes,
mucosal
sir.
happens.
Yes, yes, sir. Till now, malab, I make sure that it's like 100 is best suction pressure that I'm
Correct.
using, sir.
Good.
So if I feel like any of the system is collapsing very rapidly or something, immediately I'll tell my assistant like on water, sir. Like on the off suction and on water, sir.
Yeah.
Sir, sir.
And Mastan Sheikh, sir, can this be procedure useful indications like urothelial carcinoma, he said, for small size? I don't know. Small size urothelial carcinoma. Dr. Arshavardhan, urologist, has kept nice presentation, Dr. Pavan. Anyway, more than 120 people have attended this thing. I appreciate your enthusiasm and wish you all the best and keep it up.
Sir,
And
I wanted to ask you one thing, sir. Sir, regarding fans method, so as a beginner, so do you suggest fans method for the beginners or you tell them to first learn RS and then later you can see fans?
no, not like that. you have to learn RIRS. There is no other way. There is no doubt. But fans method is not a new thing. Like you have done it. So only thing is I am doing, even after 15 years of experience, I am doing 10 French access sheath after stenting only. The only problem with fans is access sheath is bigger. And second thing is, if you cannot negotiate beyond PUJ easily, it's a tricky job. PUJ is narrow and thin part. So in stented cases, over the thick guidewire, if under the RGP, if you can pass into the pelvis, okay. If it is not passing, pushing is same like in RIRS. In fact, you are pushing a little more. But in children, as you said, the tip of the obturator of this thing can perforate. I have shown one video.
Yes, sir. Yes, sir. Yes, sir.
Perforates. So in that case, it is tricky. Overall, 1 or 2 minor points to be added. Otherwise, it's not a great procedure. But as far as the large volume stones is concerned, once you get these fans, oh my God, it is really useful in post-stented. In fact, I am putting stent a little bigger now after a long time to not to have any problems with fans. Another problem is, first time I am seeing the length from the tip of the penis to the tip of the calyx. Upper calyx varies every person to every person. Like penile implants, like orthopedic implants, you need to have 40, 45, 50, all the 3 sizes. You have to see 40, if it is falling in the ureter, you cannot do anything.
Yes,
45, it is going into hitting the upper calyx, you cannot do anything. At least you can withdraw. But shorter one, if it is not crossing PUJ, like what you have seen in the recent conference, you cannot do it. The surgeon is good, the stone is good, everything is good, but PUJ level, it is stopped. Then what will you suck? You cannot suck anything. Suction will not be effective. The mucosa will close. So size is a concern. 10 by 12 French. Number 2 is length is a concern. Number 3 is PUJ is a concern. If these 3 things one keep in mind, like one who has done more than 100 RIRS, it will pick up, I feel. Even Oliver Traxler, sir, I shared the cases. He says that both discs and fans will have their own value in the future. So let's hope things keep on changing. Thank you very much once again.
Thank you. Thank you, sir.
Very good.
Thank you, sir.